Okay, so when you're choosing the right incision, for many years, for breast augmentation, I encourage and perform 99% of my breast augmentations through the areola. So right at where the pigmented skin around the nipple joins the unpigmented skin is a particularly easy way to hide any scar. So by going through this area and knowing where the nerves are, you can go right down through behind the muscle and place the implants in place. A few years ago, they found that the glands in the nipple itself carry a certain amount of bacteria that can jump on the implant, and while not cause an infection, can encourage a capsule contracture. So lately, I only do about a third to half of my patients through the periareolar, and I've switched and started going to the inframammary or at the crease position. So the crease position, incision, is not as artistic in my mind in that it doesn't heal quite as fast, but at 6 months to a year, year and a half, you actually have a very good quality scar there. And now with the use of the form stable implants, where you had to leave a larger incision, you couldn't put it through the areolar incision, and the inframammary placement has become the most prominent or predominant incision used in breast augmentation. Now, I went through a period in my career where for 2 years I did everything through an incision in the armpit. Even with the use of the endoscope, perfect placement through the armpit is very challenging, and most recently in that study about the bacteria around the nipple, they found that the bacteria that are kept in the sweat glands cause even more problems with capsular contractures, and they contribute to an entity called biofilm, which sort of upsets the body, and while not causing an infection, encourages this capsular contracture. Now the fourth incision that was popularized about 15 years ago was the transumbilical or belly button incision. In the vast majority of these cases, these stay above the muscle. It's a blind procedure where an incision is made at the belly button, and then a tube with a point on it is headed toward the breast, which is then held up, and then you blow up a balloon a few times in there, and then you take that out, and then you put the ultimate implant in. While these look great for a few months to a couple of years, they have a tendency to drop like bombs, and I've never really chosen to do that operation through that approach.